Okay,
good.
so
Be
like
good.
Dr.
Don't
Iyer
forget
said, I'm Shannon. I just graduated in May. I loved this class. That's why when she asked me to come back and do this presentation, I was happy to do it. So have you guys learned about emotional intelligence at all? Dr. Iyer said she talked to you about it. That is blinding. She said that she sent you out like a quiz. about it.
Yeah.
Did any of you do it?
Yeah.
You
Yes.
did. Okay. So what? Any thoughts after? Someone?
I think with emotional intelligence, like it's something that you learn as you go, and if when you don't have it, it kind of lacks in your ability to like care for somebody.
It really does, and it's something I feel like you're always working on. And if I didn't have this class, I don't think I really would have known what it was. And I feel like I would have been not so sensitive or in tune with different things that are going on because of it. So when we presented this, I think that's where she got the idea for the quiz. But I have a quiz for you guys to do too, but just more to kind of see where you're at, because this is the kind of thing you probably are doing it without even realizing, and you also could probably work on it without even realizing. So with emotional intelligence, it's the capacity for recognizing our own feelings and those of others, and that as a nurse is huge. You're going to be doing that every day, day in and day out, not just with your patients, but with their families. You're not just caring for a patient with CHF, you have to deal with his wife and children, and they don't understand the diagnosis, and they're like taking it out on you, and you have to realize it has nothing to do with you and the care you're providing, and you have to kind of tailor things to that. So that's a big thing that you will deal with every day. Motivating ourselves, I feel like that has to do with within a team. Like another nurse, you ask them, hey, can you give me a hand with this? And they kind of give you an attitude. It's probably not because of something you did or because you're asking them for something. It's probably because they're having a really rough day. And there's so many other things that can go along with that. But before I started diving into this within myself, I would have thought she was just giving me an attitude because she didn't want to help me or she didn't like me. So this is something that you can constantly be working on. And then managing emotions well in ourselves and others, I kind of just touched on that. So with emotional intelligence in nursing, increased team performance, I feel like every nurse I talk to can work on emotional intelligence within themselves, because you'll hear nurses all the time. They don't want to deal with a patient. They just want to get them discharged. They don't want to get social services to help them. And it's all these different stigmas that go along with, you're just supposed to be their nurse. Your attitude and your opinions aren't supposed to weigh in on the care that you provide. And I already in my practice have seen a big divide between nurses who want to work as a team and want to do what they're supposed to do, and then nurses who are just kind of there to like give meds and admit and discharge patients. So that's a really big thing. And then it can decrease your occupational stress, tapping into your emotional intelligence. For most of the things I've already said, if you go to work and know you've done everything you can do in your power, you're not going to be as stressed when you go home thinking, I didn't do X, Y, and Z for this patient that I could have done. But so I have a quiz that you guys can do, just because I want to see where you guys are at. So before I was able to send this out, but I think Dr. Igo forgot to. So if you don't want to type this whole thing in, you can just Google Mind Tools Emotional Intelligence Quiz, just to kind of see where everybody's at and get an idea.
Is it like a 40 question thing?
No, I think it's like 10. Maybe not. I literally just did it yesterday and I don't remember. 15. So yeah, it's not bad. And we can kind of go through it together. But I do want to see where you guys are at with that, just so we can move forward. So yeah, if you want to just Google Mind Tools Emotional Intelligence Quiz, it'll come up. Or if you want to type this whole thing in, that's fine too. when you guys are done, you can just look up, and like I said, I'm gonna see kind of how everyone did and where we're at. Did all of you find it okay? Yeah, okay, good. Just a quick show of hands, who's done?
Wait, is this the one we already took?
So, Dr. Idaho said no. She said hers was a good amount longer, she thought. So yes.
This is the one I took.
Oh, you did? Okay. Do you remember what your score was?
Oh, I have it in the thing that I
A
wrote.
reflection or something?
Yeah.
Okay. All right,
I got a
so,
53.
okay, all right, so quick show of hands between 15 and 34. Who got between 15 and 34? No one? Okay, you guys are pretty good. About 35 to 55. Okay, so that's like a majority of you. And then 56 to 75. Oh, wow. Okay, really good. So when I first took this last year, when we were like making this PowerPoint, I got somewhere in the 30s, and I really thought I would have done better than that. But then going back through it, like I said, this is something that you can constantly be working on. So I just did some of them. Oh, it didn't. So did anyone think they would have done better than they did? Or like, does anybody have any feedback from what their score was?
I thought I would have did better.
Yeah, so you thought you were like more in tune with your emotions and other people's emotions?
Yeah.
But you said you got a 50 something, that was pretty good.
I mean, I guess so.
Yeah,
Not
that's
really.
pretty good. Did anyone think they would have scored higher or lower than they did? No, you were all kind of where you thought? Okay, so the one big thing that when I got 15 to 34, it said that it would be hard to, for people that score between there, it's hard to calm yourself down after you get upset. And I feel like that kind of comes along with being a new nurse and being new in the nursing profession is we kind of get thrown into these things that we were taught about, but we don't necessarily know what to do in that time and place. Like, oh, I've learned about a patient with COPD, but now I have someone in front of me with it, and how do I need to deal with this and give meds and do that kind of thing, but then the emotional toll of a patient sitting in front of you that can't breathe, and you've given oxygen, you've given a steroid, like you've given your breathing treatment, and it's like, what else can I do? Like now I need to just emotionally be here for this person because I'm waiting for the doctor, I'm waiting for respiratory. So like I already talked about a little bit, perceiving emotions, I feel like that's big with our patients and with other people working in healthcare. I mean, I already in my 6 months of practice have noticed us as nurses, we're held to a high standard. We need to know the patient's name, date of birth, allergies, what meds they're on, and their diagnosis. And like sometimes the doctor walks in the room and has the wrong patient, they don't even know their name. And that's something that we kind of have to deal with within our own body language. We can't say to them like, are you kidding me? I know everything about this person and you're in the wrong room. So that's something that I kind of had to work on as a new nurse, realizing that's not really my place. I'm here to take care of patients and not let my pride or whatever else get into the way of that. And then breathing with emotions. After a long day of work, I feel like things hit you. Like I'm taking care of these people all day and maybe one of my patients passed away, which recently happened to me early in the morning. And I just kind of went about the rest of my shift. And then by the end of the day, it like kind of hit me like a ton of bricks. And that's something that we as nurses have to know how to deal with, and no one can really teach you how to deal with that other than just constantly working on yourself and kind of seeing, why do I feel this way? Is there a reason I'm feeling this way? Am I able to talk to other nurses about it, or is what I'm feeling validated or rational, or am I just being completely unreasonable? Managing emotions goes right in with that, and then understanding emotions, like I said, why are you feeling this way? So originally when we did this presentation, there was 3 of us, but I was the only one that told Dr. Igo to come back and do it. So my personal experience with emotional intelligence was part of the reason I became a nurse. My mom was a long-term patient in a hospital, and the nurse finally realized that like I needed help. She was like, you are here too much. Like, you need to go home, relax. And for me, that was kind of eye-opening that this nurse was here to take care of my mom, and now she's like taking it a step further and knows what's going on with me. And that as a nurse is really big, and that is part of our job that people don't realize, that we're there to take care of everyone regardless of their choices, who they are as a person, all these different things that people will judge them for. It's not our place, and we're just there to be their nurse. And I feel like in my practice I've noticed a lot of nurses who just don't want to be bothered with a patient because they think they're drug seeking, or they think that they're not actually in pain and they are. So that is all difficult when you're the kind of person who just wants to do good by their patients and follows a nursing, Dr. Igo called it the nursing code of ethics. Like, we took boards and went to school all this time to be a nurse, and now you're going to deprive your patients of things that is their right. And then my other experience was professional, which I'm sure you guys have kind of dealt with. I went into clinical one day and get my patient assignment for the day, and it was a younger, I think she was like in her 50s, and she was a normal like walkie-talkie patient before this. And she went in for like a routine surgery just to see what was going on, because she was having like abdominal pain, and she ended up having cancer in like all her female reproductive organs. So they did like a full hysterectomy. They took her appendix out because that had cancer also, and then they took part of her colon out, so she had a colostomy. So now this is a woman who, like I said, she's in her 50s, was doing everything for herself the day before, and now she woke up and she has like this bag on her stomach that has stool in it, and she has to learn how to care for it. She wouldn't even look at it, which I don't think I would have either. But my nurse was like, she's just in there, she doesn't want to talk, she won't talk to me, like whatever. It was very like turned off because, I don't know, maybe she has 6 patients to take care of, she didn't have time for it. All I did was went in that room and sat with the patient for 5 minutes, and she completely opened up. Broke down in tears, told me how like horrified she was that she woke up like this and she wasn't prepared for it, and now she has to live with this colostomy bag. And my like only thought was, all the nurse had to do was give her 2 minutes and she would have completely opened up. And that I felt like I saw a lot in nursing school of nurses maybe not wanting to deal with having a student, like they want no parts of us teaching us anything, and it's like, you were here once too. Or they don't have time for the patients, and that's what you're here for. I get it, you have 6 people to take care of, but that's your job. You're here to take care of these people. So, just curious, has anybody had an experience where a nurse doesn't want to have them as a student nurse, or the nurse doesn't, like they'll tell you, oh, this patient X, Y, and Z, like don't even bother. Just curious, can some of you guys share? Go ahead.
Yes, at one hospital, I was assigned nurse, and I actually got assigned her twice. And she just didn't want nursing students, and she was like, okay, I'll be right back, and like we
Disappear. Yeah, it's the best, right?
Yeah.
Anybody else? I saw some nods over here. What was your experience like?
Well, I had the same nurse twice, but I had said this before. She wasn't good the first time, but I think it was just personal reasons.
Okay.
And then the second
And that
time,
can happen too.
yeah, the second time she was great, but then you have, I don't know, and then you have nurses who it seems like they don't want you around, but then they'll tell your clinical instructor, you guys were great.
Yeah,
So
that's
it's
a weird
weird,
situation too. And I'm always the kind of person, like you said, she might have just had a personal reason. I mean, you don't know, like she maybe has a newborn baby, was up all night, doesn't want to be at work. But then I always like take that personal. I'm like, she doesn't like me. and I'm like gonna be a bad nurse. Like that's what I would feel like.
Mhm.
And really it had nothing to do with that.
Yeah.
But I feel like in the beginning, they didn't take us so serious, and then I think at the end, me and my friends were like, you're gonna have a student today, like you don't have any choice. But, so has anybody had the experience where a nurse, like, is treating a patient indifferently, or like had a bias? I feel like it happens a ton in psych. Are you guys in psych?
Mhm.
Yeah, any experiences with that? Like nurses treating patients indifferent? Or not, maybe not to their face, but like not giving them the care they need, or just ignoring them? Go ahead.
Well, what happened was, the gentleman, he was a psych patient, he was asking if he could shave, and the nurse was just like, not today, like, she was like really rude
Well,
to
yeah, 'cause-
him, and she didn't give him like a reason why, and the patient was just like, well, I just wanted to shave, I just asked or whatever, and she was just like really like condescending to him, and then he got mad, and he was like,
Of
all
course
you
he
had to do was tell me why, and explain, like, that's all you had to say from the first, from the start, like, you didn't have to even turn it, and the patient was actually right, you know.
Yeah, and that's a thing in psych where like the nurse holds the power for that because the patients aren't allowed to keep their razors. So if she just wants to deprive him of that right, then she's just gonna go ahead and do it, which isn't right. Anybody else? I feel like it happens in psych all the time, really? No one else? How about in med surg? Cause do you guys do weekend clinicals? And I feel like the nurses don't wanna work on the weekend, they don't wanna be bothered by the patients. Anything with that? No? Okay. So, one thing that I've definitely noticed in my practice is, about nurses not wanting to be bothered with patients is, they always taught us, if you're not feeling emotions anymore, it's time for you to move on. Move to a new specialty, try something else out, like you're burned out. And that, people not moving on, then they like look at new nurses, like you shouldn't be giving patients the rights that they deserve. Like, so for example, I had a patient a few weeks ago, he had a seizure disorder, but he lost his insurance, so he wasn't taking his seizure meds. Well, who can afford a $300 prescription for seizure meds when you have no insurance? So the doctor actually was like, well, if he's not gonna take the meds, then we just need to get him out of here, like he's not compliant. I'm like, well, he doesn't have insurance. He's like, well, social work's not gonna be until Monday, and I don't really wanna keep him here all weekend. I'm like, isn't that what we're here for? Like, he's gonna be here in another week because he's gonna have another seizure because he doesn't have his meds. Like, it's, so doctors and nurses, I feel like the ones who are burned out and don't have feelings anymore kind of look down on people coming in that are trying to just do the right thing and abide by normal code of ethics and what's just right. But so one thing about emotional intelligence definitely is check your biases. I know when I had my psych clinical, it was in like a drug and alcohol center, and I was like terrified for no reason. Like I had this whole thing in my head, and it ended up, people were just like me, they just had a drug or an alcohol abuse problem. And that was really big for me, because I realized there's no reason for me to be scared of these people, they're people just like I am, they just got stuck into this rut or whatever. So that was really big for me personally, was check your biases, even if you don't realize you have them. I didn't think that I was feeling any kind of way about addicts, and then right before the clinical, I was like all full of anxiety for no reason. And then acknowledge your emotional triggers. I know a lot of people have baggage and things that trigger their anxiety, and that's tough to deal with on a day-to-day basis. Like if you're working in a high-intense ER and someone comes in and makes you feel uncomfortable, you're gonna show that. So that was also something that we researched a lot for this, was acknowledge your emotional triggers. And I remember the girl that I did this with, she had a family member who was in and out of the ER, and they kept thinking that he was pain-seeking, and he ended up having like stage 3 cancer. And that's like just so biased. Like this poor man was actually really sick, and they just thought all he wanted was pain meds, and that happens all the time. I see it happen at my work all the time. Oh, he wants pain meds, get him out of here. And it's like, well, have you done anything to see if there's actually anything going on? Probably not. And also getting out of your comfort zone, like knowing your triggers, but also getting out of your comfort zone enough. Like if you think you want to be an ICU nurse, go down to the ER and see what it's like, just to see. And to kind of get out of your comfort zone with caring for patients, because I feel like depending on what type of area you're in, you're gonna have different types of patients. Like where I work, I have a lot of Spanish speaking patients. It's so frustrating using the phone, so I try to understand what I can, because I kind of feel bad for them that they can't just call when they need something from me. They have to like pick up this language line and go through that whole process. And also put yourself in their shoes. Do you really want someone caring for you that has a bias about you and feels some kind of way about just caring for you? Not really. I mean, would you ask for anything? No. I wouldn't ask. If someone made me feel some kind of way, I wouldn't even want to ask them for anything. So one big thing that I loved about this class was, one, it was a break from learning about disease processes, because God, my poor brain. And then another thing that I thought I really noticed between me and other people that hadn't taken it was I kind of started to pick up on different things that nurses would do when they're at the bedside with the patient. So you walk into the room, I feel like it's all about like your aura. Like if you walk in there, you're busy, you've got a flush in one hand and your med in the other, and you're like, all right, I'm gonna give you these meds. Boom, boom, you're in and out. Is the patient gonna tell you that they were up all night and couldn't sleep because of X, Y, and Z? Probably not, because you ran in there, gave your meds, did what you had to do, and that's it. And then that's the kind of thing they're gonna tell maybe the night nurse, and now it's gonna be like too late. Like now their blood pressure is ridiculously high, and they were symptomatic earlier, but their pressure wasn't showing it, and then you didn't talk to them, so you know what I mean? Now it's like later. So bedside manner is a huge thing that just, I mean, and I know you're busy. I mean, I have 6 patients. It's a lot, but if you just take the second while you're in there, and then one perk is they won't hit their call bell as much. If you give them the time of day while you're in there, they're not gonna call you every 10 seconds, because then they're gonna feel more comfortable when they're with you for that 5 minutes. And kind of goes right along with that, motivate patients to change their behavior positively to influence their health, but patients have to be willing for that. I do patient teaching all the time. A big thing is my dialysis patients, they know nothing about what they're supposed to eat. Like, I don't know if when people get diagnosed with like end-stage renal disease, if they just don't get taught what they're supposed to eat or what, but I feel like that teaching I do all the time. And I don't feel like my patients really like receptive, because they're not into it. Like they know they can still go to dialysis and get dialyzed and be good, so they don't really have to follow this regimen. But yeah, patients have to be willing to change their own behaviors, but they'll notice if you're in tune and caring about what's going on. And lack of biases, I feel like I'm beating that like a dead horse. So this was just something cute that we found about your EQ is the new IQ. I feel like I wasn't the smartest person in nursing school. I like guessed half the time because I couldn't memorize things. So that's why I really liked this class, because like I said, it wasn't about disease processes. It was about just like the heart of nursing and being there and being a person and not being a robot who just gives meds and comes in and out of a room. And I mean, now that I see as a nurse, you can look everything up. You don't need to know this lab. First off, when you look at lab values on the computer, they're right next to it. So never have to know those. And then when you are discharging someone, or if you're in the ER, before you go do patient teaching, you can print out things for yourself, which is what I do all the time, because I don't see people with hyperthyroidism every day. But I do once in a while, and I need to be able to teach someone about it. So it's always okay to ask questions and look everything up. So do any of you guys know, because you're seniors, right, do you know what kind of nurses you want to be?
I like surgical, like
Really?
post-op.
Yeah?
It's pretty cool.
I feel like I would like that because it's always different. Like what I'm finding with my job is like it's already like boring.
Gotcha.
So what kind of nursing do you do?
I'm a med surg float, so I go, there's like a general med surg floor, there's a post-op ortho floor, what's the other one? Like cardiac and pulmonary. I go to the ICU once in a while, but they give me the stable patients because I'm float. Haven't been to the ER yet. We kind of like to go there. But anyone else, what kind of nurses you guys want to be? ICU? Peds? I love peds. Anyone else?
Labor and delivery.
Oh, okay. And I feel like a lot of biases go with peds and labor and delivery, because like when I did this yesterday, the one girl was saying like if moms are choosing to breastfeed or formula feed, like nurses will like have something to say about it, and it's the patient's choice. It's their baby, it's their body. It's not your place to have anything to say about it. You're just there to care for them and in the best way that you can. And then in labor and delivery, you also deal with a lot of family dynamics throughout the labor process. So you guys already had peds. Did you notice did you have to take care of like the families as well? 'Cause
Well, I
know-
work in peds now, so
Oh,
like
you
I
do?
deal
Okay.
with like the parents when they come to see their kids, so
Yeah.
I get that.
Yeah, so what do you think is challenging about that?
The parents, because where I work, the kids stay there, they live in there, but like they're so like medically fragile that like I wouldn't say some are under the state, but some are also under us. But the
Okay.
parents will like, you know, be MIA for so long, and I just see like the nurses know so much about the kids, but at the end of the day, you still have to give the respect to the parents. At the end of the day,
Yeah.
that's their child, you know. Even though
Yeah.
you're with the child like 24/7.
And that's like
They
a
still-
hard line,
yeah.
because as the nurse, I mean, you're like emotionally invested at that
Yeah.
point, and that's gotta be hard. I also feel like that way for like NICU nurses. They're caring for this child round the clock, and the mom might not, even in that case, the mom might not be there because she might be recovering from like a section.
Mm-hmm.
So yeah, that's definitely difficult. So do you see your nurses struggle with that?
Yeah, but I think they do a good job of, they kind of like do handoffs. So if one nurse sees like one getting frustrated, like certain parents, we know like how to deal with them. So like
Okay.
if one nurse sees somebody getting frustrated, they'll like be like, she needs to take a second chance to check on another child, and then the other nurse will kind of
Oh,
like
that's
step
really
in.
nice.
Yeah.
Wow, yeah.
So they'll
that's
like go
awesome.
back and forth.
So when you did your peds clinical, did you see any similarities or no?
Yes. Well, at DuPont, the parents, the nurses, I think were really good about always involving the parents in the care, like
Well,
every
they're
single
typically at the
step.
bedside. I feel
Yeah,
like. Yeah.
they were really, really, really good about it. So even with like difficult parents, it seemed like they always just reassured them that they were doing like everything possible, and the parents seemed like at ease. So,
Yeah, well, yeah,
I
that
know.
makes it a lot easier.
Yeah.
How about any like med surg, like does anyone wanna do med surge? No? Who said critical care? So have you been in critical care and clinicals at all?
I was in the ER and then we like took someone up to the ICU.
Okay,
But I feel like just the change of pace and like
Yeah.
dealing with somebody who's critical.
yeah, and something I have noticed in critical care is a lot of the patients are on vents, and they can still hear you. And a lot of nurses act like like the patient isn't even there. And like I said, I float to critical care, and I feel like if I don't talk to this person as I'm getting a new IV on them or giving meds through their, whether it be like through a line or through their like G tube, I need to let them know what's going on. You know what I mean? I don't know, the whole vent thing is tough because I feel like I said, the critical care nurses get burned out. I mean, they deal with that stuff every day, but then it comes to a point where like, when does it become maybe too much, you know what I mean? Because they're dealing with so much. But, so with bringing someone from the ER to the ICU, did you see a difference in those nurses? Because I feel like ER and ICU nurses are like day and night.
Kind of.
Yeah,
I feel like ER nurses are very fast paced, and then you
Mhm.
get to the ICU and you kind of expect it to be fast paced, but
It's
they're
not.
like very mellow. They're like,
Yeah.
all right, like
they've got
This is what
12
we have
hours
to
to
do.
do.
Yeah.
So I feel like their patients are really critical. They know what's going on with them, but they have them for 12 hours to do all this care. I mean, they do a lot, but
Right.
yeah, I feel like you expect it to be more fast paced, and it's
Mhm.
pretty chill there. But you said you favored the ICU over the ER? Okay. Anyone else?
I kind of picked up on ER now that I'm working in the hospital as a full CA. I'm more so for the fast pace and seeing different things every day. Whereas as a regular med surg, it's the
Yeah.
same care. Like even though I'm a CA, I kind of see like you're just always giving meds, wiping someone up, talking to them.
Mm-hmm.
And then an ED, like you getting a new patient every hour or so,
And I feel like
swapping
you-
them in and out. So
Yeah, and you can see the different, like I said, I don't have someone with X disease every day, but in the ER, they're like in and out, you know what I mean? So yeah, that's a big thing, but, do you see a difference between like the way that nurses treat each other or nurses treat patients when you move around the different floors
Most definitely. Just even as far as like me being a CA with the nurse, like on one floor, the nurses don't do anything. And if the bell's ringing, they're gonna sit right there and continue to talk to each other while the patient is in the room. Could be something's going wrong. Just the other day, there was a patient on the floor who was laying there for who knows how long because nobody went in there to check on them, and a CA ended up just looking in the room and saw that she was on the floor. So it was more so like them always looking to us to answer the call bell, but if that's your patient and you're caring for them and you need to know what's going on with them, why not go in there?
Right.
Whereas in ED or like in ICU, they're like always helping us, like always going in when we're going in, asking if we need help. So definitely see that as far as on regular med surg floors than compared to the ED or the ICU.
Okay. And then how about how the nurses treat the patient? Have you seen a difference between like more hands-on or hands-off in certain places?
Yeah, I think it's just that floor in general, the nurses have like no care for the job at all.
Mhm.
Because you'll get them who like kind of speak to the patients in a way where they're like talking down to them and not directly to them.
Mhm.
And even patients pick up on it to where a lot of people don't like working on that floor. So like
Wow.
you'll get patients to tell you like, oh, like this is why they can't keep CAs, or this is why a lot of nurses aren't here anymore
Mhm.
because of the care that they provide. So,
Yeah. Yeah, that's really tough. Like, especially like if patients are picking up on it, then that means they've either really been treated indifferent or they just can tell by the fact that no one's checking on them and that kind of thing. Let's see. So a couple things about just emotional intelligence in general as like being a new nurse. I feel like big takeaways I would tell you is don't let other nurses who have been a nurse for 15 or 20 years deter you from just treating your patients like they're a person and not being indifferent towards them because of whatever biases you have. But other than that, do you guys have any questions about like boards, nursing,
Thank you.
med surg in general? Go ahead.
How do you feel that the transition has been, like, I guess, as it, like, from a nursing student to a new nurse?
Oh, you know what? I
And
forgot
you-
to talk about that.
And you
Okay.
talk about, like, I guess, nurses that have been there for a while, do you find yourself, like, giving more effort? Like, do you feel yourself more drained at the end of every day?
I talked about this yesterday. I can't believe I forgot to talk about it today. Thank you for that question. So, my first job that I picked is in a really small hospital. Like I said, I'm a float nurse, which typically is a daunting task, but my hospital has like 3 floors. It's very small. So, me being a float nurse, for me, was the best thing to kind of see everything, but still be in a small hospital. I picked a small hospital because I was so scared to be a new nurse. I was so scared to like be on my own and care for people because nursing school we get 1 patient. In the real world of nursing, I have 6 patients. And even with that 1 patient, I wasn't giving meds on my own. I wasn't making decisions. I never had called the doctor and gave them like critical results. So I chose this job because I felt like it would be good for me to get my feet wet. As much as I wanted to work in the ER, I just kind of was like, I need to do this med surg experience. Everyone said do med surg, that's what I'm gonna do. So I feel like as a new nurse, I'm the one that's like questioning things and really like into stuff because I just learned about all of it. So I'll like kind of remember like, oh, I just learned about this, but I don't remember everything, so let me look it up and like learn more. Whereas I feel like nurses who've been there for a while are not doing that. They just, this is what it is, these are the meds I need to give, and this is the charting that I need to do. So that's something that I've already noticed within a few short months is I think I picked the right place for the reasons that I picked it, but now I'm kind of seeing, just as a new nurse, that I think I want more, you know what I mean? But from student nurse to new nurse, I went like the smaller, now some girls I went to school with, they work in the ER and they love it, but I just wanted that foundation because I felt like I was a book smart person, not a skills person. So I was always nervous in clinical to do skills. So this time in med surg, I've really got to, like, I get my IVs in with every time I do them. I'm fine with like IV pumps and that kind of thing. Like I wanted that time. And like I said, from student nurse to new nurse, it was the best transition, but I'm only like 3 months in and I'm already like, okay, what else is out there pretty much. But also where I work, a lot of the nurses, like I said, have been there for a long time and they're like diploma nurses. So I think that has something to do with that they went to the nursing school that's at my hospital, and now they work there. They've never seen anything else. I've been in high, like, action ERs. I've been in DuPont's ICU, you know what I mean? Like, I've seen some crazy stuff. So I think that's partly also why I'm questioning and wanting more. But did that answer it? Do you have any other questions?
Yeah, and I don't know, sometimes I guess nursing students, they get anxious because like some of the things you learn in class, I guess you would apply to yourself and you're like, oh, I have these symptoms, like maybe I have things like that.
Yeah.
Do you find yourself still getting anxious like going into work?
About what? Like just in general?
Yeah, just in general.
In general, where I work, everyone is really willing to help. So if I can't get a line on someone, or this person has this weird pressure, but they're a dialysis patient, and dialysis patients go up and go down, like, I ask people all the time. I don't claim to know everything. I love learning, but I don't get anxious for the fact that if my patient's gonna, this is how I feel about it, if my patient's gonna crash, I'm gonna do everything I could have done up until that point, and while it's happening, and even after. Like, I feel like you just have to know you're doing everything in your power. You're asking other nurses, you've called the doctor. So like, for instance, I had a patient who I had in the ICU with step down. She was in for like pneumonia, like nothing crazy. She wasn't like a really bad case. A week later, I had her on the pulmonary floor. And I'm like, why is this lady still here? Like, I just wasn't understanding. So I'm like reading. So at my work, we have to do tele strips every 4 hours, which is hard and time consuming. You have to like measure everything, say this is the P, the QRS, and the T. So I did her 8 o'clock strip, it was good. 12 o'clock, she's got like this weird thing on her T wave. Now I'm full of anxiety. I'm like, she's gonna have an MI right here in front of me, and I know her baseline. I've had this patient before. Now she's telling me that her stomach hurts like here. And I'm like, oh my gosh, in women sometimes, chest pain isn't like chest pain. It can come lower back or abdominal pain. Now I'm really losing my mind. And my preceptor's like, just call the doctor. So I call him and he's like, oh, she's good. And I'm sitting at the nurse's station. I can see her. And I'm like, I'm not moving. Like, I'm so worried. And then next strip comes and it looks like that. So then my preceptor's like, well, look at the previous strips. Look at her EKG. So she had looked like that in the past, but she didn't look like that for me at 8 o'clock. So that's why it worried me. So a few hours go by, I give her some meds for indigestion because that's what she thinks it is. I'm like, all right, cool, get these indigestion meds ordered. She takes them. She's still having this pain. So I call the doctor. Finally, he's like, let's order a troponin. So I'm like, all right, good. Now at least I've done everything I can do. If it really is a stomach problem, I've advocated and given meds for that. If it's a heart problem, I finally got him to order something. At this point, if she were to have an MI, I did everything I could do. You know what I mean? Like, you're proactive and on top of it. Sometimes there's nothing you can do. She ended up being fine. Her troponin was fine. But I knew there could have been something going on. But as long as you, and I feel like you have, like when you're in nursing school, things seem annoying. Like, I've learned this 100 times. But the fact that as soon as I saw that T wave, I was like, no. And then as soon as she had that stomach pain, I was even more worried. Like, you think you're learning these things too many times and like, oh, I know this. Then when it happens, you will know what to do. And you won't feel, maybe in the beginning you'll feel anxious, but the first 3 months you have a nurse, should be like a senior nurse with you. So it'll be. Anyone else? I feel like people had hands over here. Go ahead.
How was the influx? And then I just wanted to know if you could give us any other insight on like the preparatory thing for prepare us for nursing.
For what was the last word?
Like some type of preparatory thing, like residency or anything like
Okay.
that.
So I didn't do a residency for the fact that I didn't know, like, I'm from Jersey, went to school here, wasn't sure where I was going to work. I kind of was sick of driving, so I took my boards, you're like, yeah, took my boards in Jersey, and I actually heard from other people, like, oh, it's going to be a pain in the butt to do it in Jersey since you went to school here. No, it's fine. I actually got my number before everyone else. I just waited because I got my number in June, and I set my test date for 1 month after I got the number, to give myself that solid month. Because after graduation, I studied, but it was like not full-hearted studying. So
How did you study for it?
So I did UWorld and I loved it, but I will tell you, week before I started getting all of them wrong and I stopped and I just used my Saunders book, that like teal book.
Mm-hmm.
Yeah.
I think I was psyching myself out.
Okay.
All of a sudden, I had been getting, and also if you do UWorld, 80% is like 100%. Because they, like, most people are in that like 80% range. But I started doing a lot worse. And I was like, Lord help me. But I just started doing Saunders because I thought I was psyching myself out and I passed. I didn't pass in 75 questions. I had 125. So, and I was terrified. I was like, oh my God, I'm failing. I'm failing. Because all my friends were like, oh, I had 75 questions. I didn't. But like I said, in nursing school, I was not the smartest person. I couldn't memorize things. So I was like to think through things. So, I mean, I passed. But other tips for boards, if you have test anxiety, just try to, I don't have test anxiety, but I think I was getting anxious. Like I said, that week before, for some reason, I was getting them all wrong. But when you go there, there's literally nothing else going on. It's just you in that room. Take as much time as you need to. Think through every question. One thing I noticed is I felt like in the questions, they would really be asking you more than one thing. Like they would be asking one thing, but you had to know a few different things as to why to rule out other things. My particular exam was a lot of older adult. I don't know why, it just was. Maybe I got them all wrong in the beginning, I don't know, probably. But other than that, boards, I did UWorld. I had this grand idea that I was gonna go back and like work on things that I struggled with. I did to a certain extent, but I also got to the point where I felt like relearning things wasn't really gonna do much for me. I don't know why I felt that way, I just did. Because I kind of felt like if I was learning it for 2 years and I didn't get it, I'm probably not gonna learn it between June and July. You know what I mean? That was kind of the point I got to. But other than that, boards questions, nurse questions, ask them please. I feel like when I was, I don't know, I wanted to know everything when I was where you guys
How
were.
did you feel
Go
on
ahead.
your first day on the floor?
First day on the floor, I had one patient, so it was like, I kept asking my preceptor, I'm like, can I chart for you? She's like, yeah. But I'm also, I'm like an overachiever. I always like am reassessing myself, like what can I do better? Now that I have 6 patients, I'm like, hey, do you want to take one of my patients? My preceptor is just like, no. But no, first day on the floor, I mean, I guess it depends who your preceptor is, but I've kind of talked to the other girls and they all seem to have pretty good nurses. And I guess it also depends where you work. But I mean, I didn't know anything about the hospital I work at. I kind of just took the job and then got really lucky that all the nurses are really helpful. But I think first day on the floor will be dependent on how many patients you have, what the environment is. I mean, if you're in the ER, you could have codes coming in all day. But like I said, I'm med surg, so like I've been working for however many months now and there has not been a code. I'm dying. I'm like, can someone please like throw a pot? Like I just want to do compressions, but that's just me. Yeah. So go ahead.
I know you said like you didn't do a residency program, but do you have like other classmates that did and like had like an ER and what was their
Oh,
experience?
yeah, so I'm like going off on a tangent. I didn't do residency because I didn't know like where I was gonna be, and they want a commitment, they want like a 2-year commitment.
Yeah.
A lot of the girls did Christiana, and I was like, that's kind of far for me to commit for 2 years. And then where else did one? Jefferson. I interviewed there, and then I kind of saw what the Jefferson ER was like in Center City, and I got scared. Because like I said, I did not feel ready in my own like self for no reason other than I wasn't like a hands-on skills kind of person. So the girls who did residencies, I know one did postpartum. She loves it. But they live closer to Christiana, and then one did med surg at Christiana. They both love it. I know one girl works in the ER at Delaware County. She loves it, like loves it. Some girls are working like critical care step down. I haven't heard of anyone that's like drowning or floundering. So have faith in yourself. I definitely knew more than I thought I did, and like I said, you have learned these things so many times that when you see it in person, you're like, wow, I knew this? And it's funny because my preceptor, I'll surprise myself by what I know. She's like, oh, I haven't heard of this in a while. And I'll like spout something out. She'll look it up and she'll be like, you were right. And I'm like, I didn't even know I knew that. It just came out. Any other questions?
I don't know whether you mentioned this, Shannon, how long was your orientation?
So I'm gonna be on nights. My day orientation was supposed to be 6 weeks. It's now like week 10 and they won't take me off because they want me to go to all these education days. They want me to go to Line Day, ACLS, like all these extra things. So I've been waiting to go to nights for weeks now and haven't been yet. But so the initial thing was supposed to be 6 weeks on days. The way that my preceptor did it, we gained a patient every week. So 1 week I had 1, 2, 3, so forth. And that was a good way to do it because in the beginning, 1 was easy, 2 was easy, 3 was like, oh, only for the fact of the charting. Taking care of 3 people is not the end of the world. Charting is a lot. You have, and you also have to realize if your patient has like a weird blood pressure and you need to call the doctor, or like say that thing I had going on with that lady, I'm not gonna sit down and chart. Charting can always wait. Yes, it needs to get done, but when you have a critical situation, you can't be worried about charting. So yeah, that was a good way to do it, gaining 1 each week. I've had 6 for quite some time now, and it is nice that I've been on orientation a little longer because I kind of bounce things off my preceptor. She literally like sits at the desk and I have the whole assignment, but I'll bounce things off of her, ask like, so in this situation, would you do this, would you do this, like that kind of thing. So 6 weeks on days, and then I'm supposed to be on nights for 2 weeks with the preceptor, and then I should be on my own. But the way that my hospital does it, if I don't feel comfortable at any point, I can ask them to extend it. Now for me, I would rather extend it on nights if I didn't feel comfortable because that's where I'm gonna be. Right now on days, there's a lot that goes on that's not gonna happen at night. Like the physical therapist is on the phone, the nutritionist wants to talk to me, this person, they're taking someone to CAT scan. None of that happens at night unless it's emergent. So all that stuff that I'm doing right now, I'm not gonna be doing on nights. So if I had to extend mine, it would be more on nights because that's what I'm gonna be doing. But no, and so my program is for new nurses, and it's a residency in the fact that once I'm done orientation, all the new nurses, we like will meet and have some kind of class. They haven't given me all the information about it yet, but I know we have to pick some kind of topic to research that's relevant to our floors. And I really think I'm gonna do bedside reporting because me and Dr. Ryder were talking about this the other day. Every winner says it's the best thing to do, bedside reporting. But really, you're like breaking HIPAA laws. And the patient doesn't want their roommate to know what's going on with them. So I'm like kind of curious like what the facts are behind that. But that's like a side note. Anything else about being a like new nurse? I don't know how to deal with your preceptor, Dr. Igo?
I'm just wondering, and maybe you talked about this while I was out fooling around. Is there bullying that's going on in your unit?
I would say, like, as much as how I've shared that the nurses have been there for a long time and you've kind of only seen what's there, they do pick up on nurses that don't want to do their job at all. Like, who are just kind of there to, like, barely go through the motions. And I actually can think of one person in particular who, like, because so you go off the floor, you have sick patients, you have to let someone know, I'm going off the floor, and the big thing I always say is like, my patient in 3, 4, and 5, they're all DNR. So God forbid something happens, do not intervene. Like I'll always at least share with the nurse I'm signing off with, even if I'm running downstairs to like grab breakfast, like this is what their code status is, because God forbid, and you resuscitate and you're not supposed to, that's a whole thing itself. So there's one particular nurse who like goes off the floor so much that they've literally like started timing, like she'll leave the floor in the morning and like the last time they did it, it was like 40 some minutes, and then the same for lunch. Well, her patients are asking where she is, the doctor's trying to like give her information and she's not there. So in that scenario, I've seen them treat her indifferent. Do I think it's okay? No, but at the same time, I'm picking up the slack when she's not up here to take care of her patients. But as far as bullying for, like the fact that I feel like I treat my patients the way they should be treated and other nurses don't, they don't treat me anyway, but they're not gonna treat their patients the way that I do just because I am. So, not really, which is a good thing. And everyone where I work is really willing to help, which I'm grateful for.
Are any of the staff in RN to BSN programs?
Not many of them. So there's a handful of nurses that are around my age group that have their BSN, but other than that, it's typically just RN. Even like, so at my work, there's a nursing supervisor, and that's the person who, when someone needs to get admitted from the ED, they find them a bed, they're in charge of staffing for the day. They don't even have their BSN, which is like crazy to me. Like, that's my boss, and they don't have their BSN. I don't know, it's weird to me, but
Yeah, and that will slowly change, and sometimes that's where the source of the bullying comes from, because you pose a threat when you have a degree to those that have been, you know, in the system for a long time and have not attained a degree.
right.
I guess Virtue is not a magnet institution.
Well, so there are other places are, but they just recently bought the hospital and the sister hospital that I work at, and those are not magnet. Their other ones are.
Okay, so they may, all the cards may all fall at some point.
Yeah, that's what we're kind of waiting.
Yeah,
But,
because magnet won't tolerate that, you know, they.
Yeah, and I don't know, one of the girls that graduated with me just got a job. I was telling you yesterday, at her place, the position was called RNBU. I have no idea what BU means, but it meant that she had to be enrolled in a master's program within 2 years of working there. I love to learn, but I don't know if that's, you know what I mean? Like, that's stipulations I don't know if I would be okay with, because what if I wasn't ready, but I loved my job, and now if I'm not enrolled, maybe I have to leave? Like, that's tough too. Because if you're not ready, you're not ready. But then I see the other hand of it where I work, where no one has a BSN. So, you know what I mean? Which side is,
Well, it never really hurts to enroll, particularly if the institution is paying your tuition.
right,
So, you know, at that point. So enroll in one course at a semester. You know, there's no.
yeah, there's not harm in that,
there's
especially if they're paying for it.
Right, I mean, they're not saying necessarily how fast you have to do it. They just wanna see that you are progressing with your career, that
Yeah.
you're preparing yourself for upward mobility. They're looking for leadership. So it's
Which I can
not,
appreciate, because I see the other side of it
Yeah.
where,
it's not so hard. The hardest part you'll ever do is what you're doing now for your BSN. And then you get some experience on top of that. The masters will be a piece of cake. Okay? Particularly if you had me for APA writing. Just saying. But, you know, it's not all that hard.
Are you thinking about transferring to another hospital to get more?
so what I've already thought about, I was talking to Dr. Drago about this yesterday, is I only work 3 days a week. So I was thinking about going and working somewhere part-time to kind of feel it out, because as much as I want to do more, I want to work somewhere else where the nurses are really helpful. You know what I mean? Even in a year's time, I'm still not going to have as much experience as the people who are helping me every day at work. So I think I might work somewhere part-time to get a feel for, like, is this somewhere I want to work? Because I know in clinicals, like, it could be like the most renowned hospital, but if the nurses are nasty, then I don't want to work there. So that's kind of what I've thought about doing, is going and working somewhere part-time in the meantime to see if I like it, and then maybe when my year's up, because you're supposed to stay somewhere for a year. But already for me, in a few months I could start applying, and by the time like I get interviews and get hired and all, it would like almost be a year. So that was my thought. And especially I really wanted to do peds and I really wanted to do the ER. I'm not doing either of those. So I think in the future that's what I'll, like when I do get a part-time job, it'll either be in the ER or in peds. So that's what I'm probably gonna do.
Is the hospital you're at now, is that a trauma hospital or no?
No, it's, so the hospital that I work at, there was a small organization and they had a sister hospital and we were like the less acute hospital. So they would send anything more acute to the other one. So, because the other one has a cath lab, we do more like same day ortho surgeries. We have a lot of chronic stable patients is like how we put it, like a CHFer that needs some diuretics and then they go home. COPDer who needs steroids, nebs, and a little bit more O2, and then they go home.
Yeah, so that's how my hospital is that I work at now. It's not
Okay.
a trauma hospital, they're connected to Hershey. So
Okay.
anything major, they either get flown out or by ambulance to Hershey.
Yep.
So working as a CA now, like a lot of people already know that I'm in nursing school and I'm getting ready to graduate. So it's kind of opening up the door for me to have a job like pretty much set.
Yeah, which is
But
awesome.
it's just knowing like if I want to stay there because they're not a trauma hospital
Mhm.
and the same, like they see the same stuff every day besides the ER. So
Yeah, no, and that's tough, and then if you wanna be or not wanna be in the ER, then you're gonna still see the same stuff. And I feel like you have, being a CNA, you probably have more experience than I had starting out, like I didn't work in the hospital when I was in school, so that's what I really wanted, that initial experience, but if you've already had it, then if you want to go work somewhere with sicker patients, you know what I mean, challenge yourself. But there's also nothing wrong with starting out there and moving once you feel comfortable.
Do any of the men in the class have any questions?
I'm just, so you guys said some critical, or you said surgical, labor and delivery, critical care, peds. Anyone else have any thoughts? What kind of nurses you wanna be? No?
I may spend a little bit of time, it's like, it's
Psych.
small, yeah.
I
Because
like
I
psych
see
when I do
like,
it.
where the patients are just disenfranchised, so it's like,
What does that mean?
basically, they're not treated fairly, like, basically on a lower scale, you
Okay.
know,
Yeah.
Well, you can change that.
treated
Go work somewhere and
equitably.
treat them the way they're supposed to be. My psych clinical was really good. I thought the nurses were good. But it also wasn't like psych. It was more, like I said, drug and alcohol, which is psych, but you're not dealing with, like the most psych that it was like anxiety and depression, which I have patients that have that all the time. It's not like a psych floor. Like some people were at, so where are you, some of you guys at? I'm trying to think, the one
Paramount?
group, where is it?
Paramount?
There, though, that group really like got a psych experience, whereas mine wasn't so
Where
much.
was yours at?
Eagleville,
Oh,
they still go there?
I don't think so.
It's, oh my lord, it's like 2 hours away, it's past King of Prussia.
It's up by LaSalle, like if you go a little
Is it,
past
like,
there.
more of a nicer one, like,
No, it's from like the 1912,
oh, really?
so old. Dr. B, my
Oh.
best friend,
Yeah.
I love that woman. You guys probably don't like her, but I love her. She's so cute. But yeah, no, you don't like her?
No.
She's gonna bring you pizza on the last day. Ask for tomato pie, that's what we got. That's so good. You don't have her at Eagleville though?
No, she got kicked out of there.
Wait, so when I asked her, wait, off the record, when I asked her for a letter of recommendation, she told me that she felt like Eagleville was like something was happening, she wasn't gonna go there anymore. So I guess that's why. She doesn't like it.
So I guess I was asking, so it might be an older building in Eagleville, but was like was the staff, were they like more uppity, like nicer, like was it cleaner?
Oh, yeah, so the thing that I felt like it was kind of was crappy was the nurses only had time to give meds, but the therapists were really involved with the group therapy and that kind of thing. But by the time the nurses got done the morning meds, it was time to start the afternoon meds because there was 2 hallways worth of patients to give meds to, and a lot of them were still detoxing, so you had those meds. They had to get vitals on every person before they gave them. Some of the patients are diabetics, you have to give insulin. And like I said, some of them have anxiety, depression, so there's med that goes with that, like blood pressure. It was, by the time they got the morning meds, they were on afternoon. So as a nurse there, they weren't really involved, they didn't have time to be involved enough with the, therapy and the group sessions and that kind of thing.
Our experience is different, it's in a worse, it's in a bad neighborhood, and the nurses actually do have time, they just opt not to be involved.
Oh, well,
And they
yeah,
talk
that's
to
a whole
them kind
nother
of,
thing.
bad, so, it's just different.
Yeah. Is it like a group home?
No, it's a hospital.
A hospital, okay.
Well, I'm at the same hospital as her, but I'm on a detox floor, and our nurses are better than her nurses.
Yeah.
Yeah, that
Yeah. Well, and that's, I
Yeah.
feel like so how even you were saying, floor to floor, the like attitude between nurses can be so different, and that really, like when you're coming in, like, yeah, maybe they're not gonna like help you and whatever, but don't let that sway the way that you care for people, because I feel like it's so easy to get sucked in and just not practice the way that you were taught and the correct, like morally right way. Go ahead.
I think too with that, because my hospital is so small, we only have 2 floors and then kind of just like wraps around. a lot of the young nurses or new grads either go to ICU or the ER, so the floor that's like that
Stagnant.
communication is all older nurses. So they're kind of pretty much set in their ways and just over it all.
And then I feel like when you bring a new face in, or like where I work, those are the nurses that when the educators come around with like new practice updates, they're like, we're not doing it that way. It's like, this is proven to be the new way for this to be the, evidence-based practice, and you're just not gonna even give it the time of day. It's tough to deal with. Anyone else?
I was just a quick tangent off of what Angelique was saying, like, where I'm at Fairmount too, and like, that's a really good psych experience, but like you were saying, like, even our nurses, with the meds thing, they're so focused on the meds that they don't really do much, but I do say, like, I've learned more from the techs than I have from the nurses.
The
Like, the techs are,
techs.
like, amazing. They know so much, they know the patients, like, kind of, like, inside and out. And they're so willing to like help you and tell you like kind of how to prep before talking to people. And I find that even with like CNAs just in the hospital, like techs or CNAs, like they seem to know more than the nurses. Not know
No,
more,
they-
but like
They're the ones that are
Yeah.
running in there when the call bell's on.
Yeah.
You know what I mean? And I am so grateful for them. Like when I have a patient who's crashing or needs me, like if my other 6 patients aren't having something wrong, I'm not gonna be able to get in there for however long that I'm dealing with a situation. So I'm so grateful for them that they're able to be the eyes and ears, like popping in there. And at my work, they do a really good job of, soon as they get a weird like vital sign, they let us know. They're like, this person's pressure is this, or this blood sugar is like 450, which is nice because some places, I don't know, like I felt like in clinical, they would put it in the computer, they wouldn't say anything. And then you go to give your next med and you go to check the vital signs and you're like, his blood pressure's 200. I had no idea. It's now an hour later because I was giving meds to 5 other patients. So, you know, I am so grateful for them, but and also I know that they are typically the ones that know patients. And also they're the ones helping them go to the bathroom, turning them. So, yeah, I feel like they get the best relationship with them because I'm so busy. Anyone else?
Shannon, how did you develop a relationship that was workable with your CNAs and techs?
So
You personally.
that actually was kind of tough for me because I'm 22 and some of the CNAs at my work are much older than me, like could be my mom. And at first I felt like they really didn't respect me and they felt like if I was asking them to do something, it was because I didn't want to do it. And it's because I'm giving meds to 6 patients and doing X, Y, and Z and on the phone with the doctor. And like, I also feel like I really shouldn't have to explain myself because I'm not doing it because I physically don't have time. You know what I mean? I'm not the kind of person to just sit at the and some nurses are. They'll sit at the nurse's station and not answer a call bell and have the tech clean their patient up. If I'm in there and they need to go to the bathroom, of course I'm taking them. You know, like, so I'm proactive. So I actually was kind of upset when like they didn't take me serious or acted like I was just asking them to do it because I didn't want to do it. One time my patient like left the floor and she had been bleeding everywhere. And I asked the CNA, I was like, while she's off the floor, I'm gonna do this admission, are you able to like change the sheets in there? And she gave me this face and she was like, that's my job, isn't it? I was like, I'm just making sure that it gets done because if I don't ask and then it doesn't get done, I'm gonna feel like maybe I should have asked, or now I'm scrambling to do it. And this particular patient was, like I said, bleeding everywhere. She was in so much pain, screaming. Now I have to change the bed when she's back in the room. You know what I mean? So that was hard for me, but I feel like, I don't know, I'm like super emotional, and I wanted to like say to them a few times, like, I'm doing the best I can, but I found it better for me personally to just show that I'm not the kind of nurse that sits at the nurse's station and chats. Like, I'm always, like, we have our like MAC machines, we call them. They're like the rolling like computer that we take to do our meds. I literally chart on that because I'm always so busy. Like, I'm never sitting, and the only time I am is if I'm like calling the doctor. So I feel like with only a few months of working, me not being the nurse that sits at the nurse's station, they respect me a little bit more. Because like I said, I mean, I went to college for 4 years, I'm in my 20s, and these CNAs have been a CNA for 20 years. So I can kind of see how first they didn't like take me seriously, but for me personally, I just, like I said, felt that it was best to just kind of show them that I wasn't delegating for the fun of it. I was delegating because I really don't have time. But other than that, if you really do have a problem with the CNA or they're not helping you, I guess just talk to your charge nurse. I mean, at my work, they've been pretty good about holding people accountable. So yeah, talk to your charge nurse, talk to your preceptor, or maybe even just talk to them and say, hey, listen, I'm really trying to do what I can do, but right now I cannot get this patient up to go to the bathroom because I have X, Y, and Z else to do. And maybe they'll understand, maybe they won't.
I think the heart of that emotional intelligence, this was a very good example of how you approach that as a new person. You know, when you showed emotional intelligence by not like attacking back when somebody gave you a snarky remark. And something inside of you told you that that wouldn't have been a good choice to do
Yeah.
that. That wasn't gonna develop a relationship going forward. So, you know, those are the kinds of things that, you know, the real life situations, and they're doing their diaries too. You know, the real life situations that kind of challenge you personally to behave a certain way or not, that's what you really have to be aware of. And know that at somewhere down the road, you may have, you know, like, all you have to do is give one snarky remark to
And
somebody.
that will never do anything for you.
They will never do anything. So it's all about, you know, your personal awareness and being aware that the other person might just feel threatened. You might have been challenging that person,
Yeah.
and not even realizing that they took it that way.
Yeah, like maybe I was insulting her by asking her to
And you
take that
didn't
bed
even know
because that's her
that
job.
you did, right?
But I don't know if she really does it every time someone leaves the floor, you know? How is that supposed to
Exactly.
But, yeah, so I.
So there can always be another time that you can sit down and say, you know, like, open that conversation in a lighter moment
Mhm.
and actually get to know that person better. So, and then they'll want to do stuff for you all the time.
Mhm.
But it takes a while for both people in that, you know, the nurse and the CNA to kind of trust one another. And we really don't do it with bad attitude or, you know, having bad communication.
Well, and the thing is, like, so if one of my patients crashes, I don't need them to then be giving me an attitude because we had words earlier.
Correct.
I need them to be there and be helping me and doing what they can do, you know what I mean? Like, that's kind of the way I see it, is like, right now it's about cleaning someone up, but in 3 hours it might be about, we're having a stroke alert and I need you to help me do this neuro assessment because there's 10 doctors in the room and like, whatever. So yeah, so go ahead, Ashley.
I had the perfect word. Is there anything that like, grosses you out during nursing, like that you don't like doing or?
I really like doing IVs. Blood doesn't really bother me. You know what I don't like is snot. And the stuff that comes out of trachs. Like, I am no nurse for that. Like, I call respiratory. Like, hey, can you come look at this? And I'll be like, can you show me how to suction that? And they just do it. I mean, I'll do it. I'm a nurse. But it grosses me out so bad. And it didn't gross me out on kids. Because when I was at DuPont, a lot of the kids had trachs. That didn't gross me out as bad. I don't know why it does on adults, but yeah, I don't know, just me.
Do you have to change patients a lot?
What do you mean?
Like, you know, if they have school or something, do you
Oh,
have to?
all the time, yeah. And the best is like when I go to like, cause we have to do like a 4-eye skin assessment on admission and it doesn't always get done right away. So I try to like do things all at once. Like, I don't like to go into the room 15 different times to do 15 different things. I want to bring everything in with me so I have a few minutes with the patient to really like, all right, I'm doing an assessment, I'm going to give meds, I already have the vital signs, you know what I mean? Like, that's kind of how I try to do things. And I also try to get a baseline for my shift because I kind of don't believe anything I hear in report because you don't know what kind of nurse that person is. Like, sometimes you'll get a nurse who tells you, oh, this patient was fine, da-da-da-da, they're awake, alert, and oriented times 3. I go in there, they don't know what planet they're on, they don't know who I am, they don't know where they are, and I'm like, the other nurse said you were oriented times 3. So I try to get my own baseline for people, and with that, I always will like turn them and see if they have breakdown, because we get a lot of patients from like long-term care facilities, and if they have breakdown on admission, we need to know about it, because if we don't catch it, then we can get like dinged for it. So that always happens, is like I'll be checking someone's skin and then I have to clean them up, but it just becomes second nature. Like I really don't even, if I do that and then I go Weight Watchers, like it won't bother you.
How we doing?
We good?
We're good.
Okay.
Any further questions, write them on your sheet. Shannon will appreciate the feedback.
Yeah, that's another thing I haven't done well with as a new nurse, is my preceptor doesn't give me any